Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared, our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned Dr. Surendra Kumar Sharma. Sir is the endocrinology professor at the Department of Endocrinology at Mahatma Gandhi Medical College, Jaipur. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is changing phase of diabetes management. Now, without any further delay, I would like to welcome Sir to our forum and would like to hand over the session to him for his precious talk to begin with. Over to you, Sir.
Thank you, Sarah. Good evening, dear friends. Today we are going to look at what are the changing aspects of the diabetes and its management. When we say diabetes, it is a disease which is having different types. One is type 1 diabetes, which are occurring in younger age, where we start right from the beginning insulin. Then type 2 is the most common type. And then there is a gestational diabetes and then secondary diabetes. So today we are going to mainly highlighting the changing phases of type 2 diabetes and its management. So as we all know that the burden of type 2 diabetes is huge. At present, we are having more than 77 million diabetic patients in India, and we are just second to China. And it is expected that within few years, we are going to be first in this, you can say, bad journey of a number of diabetic patients in the world. We are having unique features of diabetes. We are having huge burden. Our pre-diabetic patients are also very high. And we look at the pre-diabetic, you find that these are the patients who are going to develop diabetes in time to come. And the conversion rate of pre-diabetes to diabetes is very rapid in Indian context. So we Indian are having some differences than the other population of diabetes. Our diabetes is occurring at a younger age. We are having lower BMI, but our adiposity is more, and we are characterized by, you can say, abdominal obesity. We have very high levels of lipids, that is low HDL, high triglyceride, and small dense LDL. Our inflammatory markers like CRP is very high, and the development of cardiovascular disease is also very high in Indian diabetic patients. Another important thing is the control of diabetes in India is very poor. Only something like 30% of our patients are having a good control of HbA1c of less than 7%. Otherwise, the patients are having uncontrolled hyperglycemia. There is a, you can say, unmet needs in type 2 diabetes, like increasing the prevalence of diabetes. There are huge risk of complications in our diabetic patient, high cost of treating our diabetic patient, and difficult to achieve glycemic targets, that is a HbA1c of less than 7. In addition to that, patients of diabetes are at increased risk of complications such as cardiovascular disease, nephropathy or kidney disease. Heart failure is also very common in our diabetic patients. So here you find that if the person is developing diabetes, he lost something like 6 years of his life expectancy. And if he is having diabetes and cardiovascular disease, he is losing something like 12 years of his life expectancy. If he by chance is having additionally diabetic kidney disease, then he is losing something like 18 years of life expectancy. So diabetes is a disease which is characterized by long-term complications. So here we say how to define diabetes. On one hand, we say it is a disorder which is characterized by decrease in insulin secretion, increase in insulin resistance, and development of complications. And you have patients who are young or old, you are having many different aspects of diabetes. So here is a story of 6 blindfolded wise men and the elephant. So they look at each part of the elephant and then they say, for example, an endocrinologist will say it is obesity, metabolic syndrome, or diabetes. Gynecologist will say it is polycystic ovarian syndrome or GDM. Gastroenterologist will say it is non-alcoholic fatty liver disease. Oncologists will say it is having malignancy because diabetics are also having high risk of developing malignancy. A nephrologist will look at kidney failure, and a cardiologist will look at heart failure and cardiovascular disease and hypertension. So what start first and what visible first is different. We know that diabetes, type 2 diabetes develops gradually. It takes years to full-fledged diabetes to unfold. So here you find different types of even type 2 diabetes. In one of the landmark study in Scandinavian country, they looked at 5 clusters which are based on 6 variables like GAD antibody, age at diagnosis, basal BMI, HbA1c, HOMA, beta, and insulin resistance. And these patients are clustered because they are having different patient characteristics. Risk of diabetic complications are different and different disease progression, and genetics are also different in these patients. So they came out with these 5 clusters. The first cluster is just like type 1 diabetes, early onset, relatively low BMI, insulin deficiency, and they may be GAD positive. The next cluster is SIDD, that is severe insulin deficient diabetes. It is again occurring at a younger age, relatively low BMI, insulin deficiency is there, but they are GAD antibody negative. Then SIRD, that is severe insulin resistant diabetes. These are the patients who are having high insulin resistance. They are obese or overweight, and they develop complications in the form of hypertension and kidney disease. MOD is mild obesity related diabetes, and mild obesity is associated with no increase in insulin resistance, but they are having milder disease. Other is mild age-related diabetes, that is occurring in older patients, and these are having milder disease. Similar to these Scandinavian clusters of type 2 diabetes, in India, Dr. Mohan and his group has identified cluster analysis using following variables like age of disease, BMI, waist circumference, HbA1c, serum triglyceride, serum HDL cholesterol, C-peptide, and C-peptide stimulated. And they came out with 4 clusters in Indian context, and these are SIDD, that is severe insulin deficient diabetes. Other is insulin resistant obese diabetes. The third is a unique combination of combined insulin resistance and deficiency diabetes. And the fourth is mild age-related diabetes. So these are some having different characteristics as compared to the Scandinavian clusters. So subcutaneous and intra-abdominal fat is higher in Indian diabetic patients, and you find that we are not having high BMI, but our adiposity is high, and this is leading on to this superficial and intra-abdominal, you can say adiposity, which is high. And if you compare our adiposity, you find that in South Asian patients, the visceral adiposity or subcutaneous adiposity, both are higher as compared to Europeans. So dear friends, diabetes is just a part of complex disease clustering. Just as cardiovascular, renal, eye, foot, and liver diseases, you find that there is a conglomeration of cardiac, renal, adipo-metabolic, eye and liver disease, and together we label them as caramel disease. So in caramel disease, how the disease develops? The disease develops, and this is a way of explaining it. You have empty store, you keep on putting things inside. But once the store is full, then you have to keep the things on the floor. This is called excess amount of things which are there in your house. Similarly, when the fat is there, you deposit the fat in the adipose tissue, but ultimately they exhaust in storing, and then this fat goes into ectopic storage. And for example, here you can see the insufficient or inadequate storage of fat leads to this fat going to liver and producing non-alcoholic fatty liver disease. It goes to cardiac area and produces ectopic fat. It goes to pancreas and it causes increased fat in the pancreas and lead to decrease in insulin secretion. It also deposited in muscles and causes insulin resistance in the muscle. So the same thing is highlighted here. Because of the excessive positive energy balance, there is a storage of fat. But once subcutaneous and buttock and thigh areas are, you can say, full of adipose, you can say fat, then the free fat is now acting as a lipotoxicity, and it is a bad ectopic deposition, and you find that it relates to promotion of insulin resistance, inflammation, oxidative stress, and it leads to development of metabolic disorders. Same thing is highlighted in this cartoon, where excess amount of calories, sedentary lifestyle, that fat is deposited in liver, in muscles, and in pancreas, and it leads to hyperglycemia and also lead to rapid or accelerated atherosclerosis. So this caramel, as we all know, is a type of, you can say, toffees, but here we say caramel means cardiac, renal, adipo, metabolic, and liver disease. So all these things are occurring because of this same principle, and these are the tissue-specific manifestation of the disease. And diabetes is not a cause, but it is one of the, you can say, amalgamated symptoms of this caramel disease. So it is adiposopathy, which leads to all these developments of dyslipidemia, dysglycemia, hypertension, oxidative stress, insulin resistance, and other complications. So this is, in fact, is caramel. Diabetes is just the manifestation of caramel disease. So now we are not just looking at hyperglycemia, but we are looking at diabetes with cardiovascular disease, renal disease, obesity, and you find the liver is also involved. There is a metabolic syndrome associated fatty liver disease and retinopathy. Obesity is increasing worldwide, and it is also rapidly increasing in our population also. Even young patients or young population is like young kids are also developing significant amount of obesity. And we all know obesity is associated with large number of diseases, whether it is metabolic diseases like diabetes or hypertension, dyslipidemia, or you find that non-alcoholic fatty liver disease, or even malignancies are also very common in our diabetic patients. They are also lead to mental abnormalities in the form of depression and anxiety. And here you find that there are two things happening here. One is metabolic capacity, another is metabolic load. So on left side, you can see the patient is lean and thin and the fat mass is less. This is the European phenotype. As compared to that, if you look into Indian phenotype, these are having less amount of lean fat. Lean fat means muscle mass, and more of adipose tissue or fat mass. And this lead to development of all these metabolic disorders. Another theory which was propagated by mechanic and all are that this is adiposity, dysglycemia-based chronic disease model. So what happens in stage 1? There is a genetic, environmental, or behavioral abnormality lead on to excess calorie intake, leading on to stage 2 of pre-diabetes, you can say pre-disease, where there is increased amount of fat, increased amount of overweight, increased amount of abnormal fat distribution, and abnormal fat function. And then these are patients who are having cardiometabolic and biomechanical disorder. Once the patient is having obesity, this leads to dysglycemia-based chronic disease model, because now the patient is having significant insulin resistance, which progresses to pre-diabetes and then to diabetes. And we all know that diabetes is characterized by both microvascular and macrovascular complication. Further on, these patients will lead on to develop, you can say, cardiovascular disease like subclinical cardiovascular disease, and then atrial abnormalities, asymptomatic CSD, heart failure, and atrial fibrillation, and then, of course, progressing to symptomatic coronary artery disease, heart failure, and atrial fibrillation. So the thing started with excess calorie intake, fat deposition, insulin resistance, and diabetes, and on other hand, development of cardiovascular disease. So dear friends, if we can reduce weight, like greater weight loss leads to improved health outcome. So towards greater weight loss and overall health improvement, you can see if a person can lose up to 5% of weight, there will be improvement in hypertension and hyperglycemia. If he loses 5 to 10% of weight, then there will be prevention of development of diabetes and non-alcoholic fatty liver disease, polycystic ovarian syndrome, and dyslipidemia. If he can reduce 10 to 15% of his weight, then there will be significant improvement in cardiovascular disease, urinary incontinence, NASH, that is non-alcoholic steatohepatitis, sleep apnea will improve, and knee osteoarthritis will also improve. But if the patient can lose more than 15%, then there may be remission of diabetes and significant reduction in cardiovascular mortality, and heart failure with preserved ejection fraction will be improved. So our focus is now going towards the upstream approach. Upstream approach means patient is having excess of calorie, deposition, excess adiposity, and then he develops all these, you can say caramel or dysglycemia or adiposity-based disorders. So if we can reduce the weight right from the beginning in the upstream approach, then we will be able to control all these metabolic disorders. If person can lose 15% of his overweight patients can lose 15%, there are studies like direct study in UK which highlighted that after losing 15% of weight, there is a reversal of diabetes in about 50% of these patients. Another aspect is that the type 2 diabetic patients are having high risk of developing chronic kidney disease, atherosclerotic cardiovascular disease, and heart failure. And now we are having good drugs in the form of SGLT2 inhibitors, GLP-1 receptor agonists, etc., which will target or which will look into these aspects. So the Caramel study explains the high prevalence of comorbid complications in our Indian diabetic patients, where we have high risk of atherosclerotic cardiovascular disease, uncontrolled diabetes, kidney disease, retinopathy, and MAFLD, or you can say non-alcoholic fatty liver disease, and higher BMI. So there are studies in which one, myself was also involved. They looked into newly diagnosed type 2 diabetic patients and what is the burden of cardiovascular disease at the time of newly diagnosis of diabetes. And we find that the newly diagnosed type 2 diabetic patients are at high risk of developing atherosclerotic cardiovascular disease. Asymptomatic coronary artery disease in diabetes is also very common. They say that something like 10 to 47% of our Indian patients are having asymptomatic coronary artery disease, and as the time advances, they will come to us with the full symptomatology of cardiovascular disease. Cardiac renal metabolic risk continuum is continuous. As the years are advancing, we find that more and more patients are going to develop these cardiac renal abnormalities. So can we intervene at this stage where the patient is having upstream approach and we can prevent the development of cardio-renal complication rather than treating these complications? So now our focus should be on preventing the disease and looking at prevention of all these complications. So redefining therapeutic approach is also important. Now we are not only looking at hyperglycemia, but we are also looking at risk factors for the development of cardiovascular disease, nephropathy, and liver diseases. So treating the patient with glucocentric approach may not address the other comorbid complications which are associated with caramel disease. So there were mainly three eras of diabetes management. The first era was way back 20 years back or so. We used to look at the glucose level and our energy was utilized in normalizing glucose profile of our patient, and we were having evidence also like UK PDS study in UK where reducing the hyperglycemia, making the patient euglycemic leads to development of less complications of diabetes. And then there were conditions, there were studies like Accord, VADT, and Advance, where after 10 years of uncontrolled hyperglycemia, when you apply good response, good treatment, intensified treatment, and reduce glucose, there is no or minimal macrovascular benefits in these patients, and there are chances of increase in hypoglycemia. And we all know that accord was stopped because of increase in all-cause mortality. Selecting the HbA1c target is important, of course, but a reasonable goal of therapy might be A1c of less than 7% in most of our patients. The second era of glucose control was not only controlling hyperglycemia, but avoiding development of hypoglycemia and weight gain, and multi-pronged approach for the cardiovascular risk reduction. So we are not only glucose lowering approach, but also looking at hypertension, dyslipidemia, weight, smoking, etc. And the best example is Steno-2 trial. When they intensified this type of approach, they were able to reduce the cardiovascular events by more than 50% in those patients. The third era is the era of paradigm shift, where there is a clear-cut, you can say, shift in our approach. This approach developed after cardiovascular outcome trial, and we had new drugs development, which is like GLP-1 receptor agonist and SGLT2 inhibitors. These drugs are cardiovascular and renal protective, and we know that now our aim is to protect the organ. So this is the era of organ protection. So whenever we have a diabetic patient, we go for good control of hyperglycemia, good control of cardiovascular risk factors, and also try to give these drugs which are organ protective drugs like SGLT2 inhibitors and GLP-1 receptor agonists. Our understanding of the disease developed from Dr. D. Franjo's talk in the ADA venting lecture, where he highlighted that there are 8 defects which lead to the development of hyperglycemia, and he labeled it as ominous octet, whether it is decrease in insulin secretion, increase in glucagon, incretin defect, increased lipolysis in the adipose tissue, there is decrease in glucose uptake in the muscles, that is insulin resistance, increased hepatic glucose output and neurotransmitters, and of course, increase in glucose reabsorption from the kidney. So with the understanding of this ominous octet, the evolution of the management of type 2 diabetes is there. Earlier, we used to treat our patient with sulfonylurea, insulin, etc. Our aim was to reduce HbA1c. Then came an era where we were having drugs like TGD, that is pioglitazone, DPP-4 inhibitors. And here we were not only reducing HbA1c, but avoiding hypoglycemia. But the next phase was the drugs like GLP-1 receptor agonist, SGLT2 inhibitors, and now we have dual GLP and GIP receptor agonists now available, like tirzepatide, which is organ protective therapy. So on one hand, we are reducing hyperglycemia, we are looking at risk factors for the cardiovascular disease, and we are providing organ protective drugs in the form of GLP-1 receptor agonists or SGLT2 inhibitors. So the need for combination therapy in type 2 diabetes is there. We know that diabetes is a progressive disease. There is a suboptimal glycemic control, and a single drug cannot target all the 8 ominous octet and can lead to, you can say, correction of metabolic derangements, and combination of therapies are required so that you can target different drugs will targeting different aspects of pathophysiology of diabetes, and we will be giving these combinations so that we can approach good control and avoid development of complications of diabetes. So earlier we used to treat our patient by a stepwise approach. First diet and exercise, then one drug, then up titrating the drug, then bringing in a 2-drug combination, then bringing 3rd drug, and then of course basal insulin, and then intensified multiple insulin injection. But now what is the approach? Approach is you use 1 or 2 or 3 drugs simultaneously and bring the HbA1c fast below the 7, and now follow this patient. You will find they will remain in good control for a long time, and once there is a small increase in HbA1c, you up titrate the doses or you bring in new drug in the addition to those already there. And ultimately, most of the time, your patient will be having a HbA1c of less than 7, as compared to stepwise approach, where you find that patient is having a zigzag type of presentation of control, and most of the time patient remains in higher hyperglycemic range. There are studies clearly telling us that if we can achieve a good control in 1 year of diagnosis of diabetes, then in next 5 years, there is a significant decrease in development of complication. So in this study, they looked at those patients who are failing to achieve good control in 1 year, and at 5.3 years, there is an increased risk of myocardial infarction, stroke, heart failure, and composite cardiovascular events in this patient. So these are the increased risk once you are having a delay in achieving good control within a period of 1 year. So dear friends, drug complements, they are not competitive to each other. Here you can see, you are my best pal. There are good drugs, you combine them, they have different mechanisms of action, and they target different aspects of the ominous octet, and they achieve good control. The same thing is highlighted here, that multifactorial pathophysiology of type 2 diabetes is targeted by combination of oral or injectable drugs, and thereby you will achieve good control, a durable control, and development of complications will be delayed. And then initial combination therapy according to ADA is that if the HbA1c is at the range of 9 or more, but ACE guidelines telling us that if the HbA1c is more than 7.5, you can start using a combination of 2 drugs. So here you find dual therapy and triple therapy, and many of these drugs in you can say in patients who are having sulfonylurea or insulin, these are the 2 group of drugs which causes hypoglycemia and weight gain. Otherwise, most of the other drugs are do not cause or very little chances of developing hypoglycemia, and most of these drugs are either weight neutral, or drugs like GLP-1 receptor agonists or SGLT2 inhibitors lead to weight reduction also. So with that background, if you see, we are giving only metformin or sulfonylurea, you are having powerful early efficacy, but the durability will be short. But when you are using metformin and DPP-4 inhibitors, you are having weight and BP reduction. And then ultimately, when you are using metformin with the SGLT2 and DPP-4 fixed dose combination, there is low risk of hypoglycemia, and cardiovascular and renal benefits are there. So dear friends, the changing aspects of management of diabetes is that now we are not only looking at hyperglycemia, but as the patient is type 2 diabetic patient, we look at caramel approach. That is the new central pillar of type 2 diabetes care. In addition to hyperglycemia management, blood pressure management, weight management, lipid management, we use drugs which are organ protective, like cardiovascular, heart failure, and kidney benefit drugs are there, like SGLT2 and DPP-4 inhibitors. And we are using them, SGLT2 inhibitors and GLP-1 receptor agonists. So time to manage diabetes is now, we are managing it differently. There are foundational therapy like SGLT2 inhibitors, RAS blockade, statin, and if required, aspirin. And then we are additionally using drugs which are causing decrease in glucose, blood pressure, lipid, weight, cardiovascular risk factors, and abnormal, you can say, proteinuria in the kidney. We also look at drugs which causes decrease in lipid abnormalities. So looking at mild, moderate, or severe lipid abnormality, and we treat accordingly. So the unmet need of type 2 diabetes is now looked into early and good glycemic control with low risk of hypoglycemia, prevent weight gain and address hypertension, and address other comorbidities like cardiovascular disease, heart failure, and CKD. And today is the era of organ protection, and that's why we are using drugs like SGLT2 inhibitors and GLP-1 receptor agonists. So diabetes is not just hyperglycemia, but it's a combination of multiple factors, and we have to target each and every factor in the management of our type 2 diabetic patients. I think I should stop here, and if there are any questions, we can take it. Thank you.
Thank you so much, sir, for your wonderful presentation. We have few questions from our audience, if you like to take that up.
Please, please.
Yeah. So, sir, the first question is there a link between irregular meal pattern and diabetes?
Well, as regards meal, we usually say that in a diabetic patient, it should be a regular meal. Means we usually say that 3 meals, 3, you can say snacks. So because your patient is on some anti-diabetic drugs also. So if he misses a meal, then the chances of developing hypoglycemia is there. So we say that you should have 3 meals and 3 snacks so that sugar will be not going very high because you are using limited calories, and in between you are taking some small snacks in the form of, let's say, 2 biscuits or some apple or some small amount of nuts and berries, etc. And then you will have no chance of developing hypoglycemia. So this is how we approach. Thank you.
Thank you, sir. So, sir, the next question from our audience is, what is diagnostic criteria for complication of diabetes, either micro or macrovascular, and management updates?
Well, diabetes is a disease which is characterized by development of chronic complications like microvascular and macrovascular. Microvascular, we say, when the small blood vessels are involved. Now, small blood vessels are present in retina, in kidney, and in nerve fibers. So once these vessels are damaged, that organ is damaged. And that's why we will have retinopathy, nephropathy, and neuropathy. As compared to that, we have macrovascular disease where larger vessels are involved. And here the process of involvement is accelerated atherosclerosis. So because of that atherosclerosis, there is a narrowing of the, you can say, lumen of the vessel. And then ultimately those plaques rupture and there will be thrombosis. And then a part of organ will be devoid of blood circulation. For example, if the coronary arteries are blocked, then there will be myocardial infarction. If the brain artery is blocked, then patient will have stroke. Similarly, in the lower limb vessels, which are larger vessels, if they are blocked because of atherosclerosis, then patient will have peripheral arterial disease and the blood supply to the distal part of the limbs will be retarded and the patient may develop gangrene. So this is how we are looking at micro and macrovascular complications. And to achieve this, on one hand, good control of hyperglycemia, blood pressure, lipid abnormalities to be targeted, stop smoking, and doing physical activity. Meals should be at times. We should be without stress, and we should have a good sleep also. So all those things will lead to retarding or stopping or not allowing complications to develop in our diabetic patients. Thank you.
Thank you, sir. So, sir, the last question from our audience is gender role affect health behavior? And is there a relationship between gender role and health behavior on type 2 diabetes management?
You are saying general rule or gender rule?
Gender role.
Gender role. So
yes, sir.
In diabetes, there are some studies which say that type 2 diabetes is a bit more common female, because in Indian context, if you see, after 1 or 2 or 3 childbirths, ladies gain too much of abdominal obesity, and this is a disease which is associated with insulin resistance and development of diabetes. Otherwise, more or less, we say that it is affecting both the genders, male as well as female. As the age advances, our patients will develop diabetes. In Europe and in America, the diabetes is usually developing in 40s and 50s. But in Indian context, we are having patients who are developing diabetes in their 25, 30 and 35 and 40. So we are developing diabetes 10 to 15 years before what the Caucasian population is developing. Our patients are also developing more cardiovascular disease. We are having more insulin resistance. We are having very, you can say, poor insulin secretory capacity. So all those things lead to development of early disease and development of more complications of diabetes, whether it is microvascular or macrovascular. Thank you.
Thank you, sir. That's all from our audience, sir. With your permission, we can conclude the session.
Absolutely.
Any last remark from you, sir?
No last remark for our patient. I can say that diabetes is a disease which is lifestyle disease. They should go for early detection of diabetes because half of our patients are not knowing that they are diabetic. So whenever there is a patient who is coming because of some other problem, they should always check their blood glucose. Blood pressure is also to be looked into. Weight of the patient is very important. And prevention is far, far better than treating the diabetes. These are my, you can say, message to our patients. Thank you.